Today's class was on dural AVF, but I felt that since we did spinal AVM last time, let's just finish off AVMs in the first go and then do a class on dural AV fistulas on 29th. So, is there any question from previous class? Anybody who has any questions, I can take it, or we will start this class in a couple of minutes. Are there any questions that you have seen in your topics that you feel uh, are there being asked in AVM or in dural AVF, which I would then want to cover in the lecture, especially if you have anything in your MD exam question papers, which you might feel that needs to be covered, because otherwise, brain AVMs and dural AVFs are an extremely uh, rare topic. Of course, you see those patients in your uh, diagnostics sometimes, so you should be aware of this modality or this, pathology itself, that it could be AVM. But again, no class will be able to fully cover the extent of treatments in brain AVM, and also the thought process that goes in each case. So I will also be sharing a few slides on an ARUBA trial, which was basically comparison between unruptured AVMs, and whether, in unruptured AVMs, whether you have to do anything or not. So what is the risk that an AVM which has not ruptured till now will bleed, or whether you should treat it. So you get a patient at headache, suddenly you did an MR or a CT and you found that there is a AVM. So what has to be done in those cases? And a lot of it was driven by the findings of a trial called ARUBA trial. The reason for mentioning it, and maybe I'm putting in a few slides also on it, is that it might be another important question that may be asked in your DM exam, because it's even from the small question that which trial is used, was conducted and gave data regarding treatment of unruptured brain AVMs, and then what were the few drawbacks of that trial, how things have evolved over a period of time, and what is the risks of factors that are there for brain AVMs, where you might have, end up having a rupture. So what all you can look at in the scans, which can help you understand that this AVM might rupture and the other one might not. So there are certain risk factors that we have to keep in mind, and those also I will be mentioning. So now I'll try to get started with the class. So the basic idea in brain arteriovenous malformation is it's a congenital vascular disorder, and it is basically the normal usual capillary bed that is there between the arterioles and venules, that is replaced by a mesh of abnormal vascular channels. So these abnormal vascular channels is what we call NIDUS. So you will hear in your lectures in school, in RMD, and people talking about these things, NIDUS, NIDUS, NIDUS. So what is NIDUS? It is basically the mesh of, abnormal uh, good evening. Good evening to everybody. And the uh, so the idea behind the nidus is that this is low resistance vascular channels. So why it is different from the capillary bed? Because there is parenchyma, and the parenchyma has this capillary bed. It has a different kind of resistance, whereas these channels don't really have significant brain parenchyma between them, and they are extremely low resistance. So there is rapid flow of blood from the arterial side to the venous side. As a result, it also creates, from adjacent area, it sucks blood. It's like a slight black hole also, that the adjacent areas can have a steal phenomena, because if you find, you have two areas to go, one which has low resistance, other is high resistance, things will end up going through the low resistance path. That is law of nature. So when you have these low resistance channels somewhere, the adjacent areas will get lesser blood supply and more will go through these channels, and it's basically a steal directly into the venous side. There is risk of bleed per year. So now when you have this AVM, why is it important? Because it can bleed. And the risk around 1% of bleed per year, and the cumulative risk is high if you find this in a young patient. So now you have a patient who is 15 years old, 18 years old, has fought this risk, has found to have this AVM. Then the problem is that he has a risk of bleeding per year. Even if it's 1% per year, when you cumulatively see, the risk is pretty high. So I will be showing one formula in between where you minus the age from 105, and that is the lifetime risk of rupture. And again, that's important. Sometimes it's very difficult to really take that call in ruptured aneurysms. Other manifestations, as I said, it could be a seizure in that area where the AVM is. Of course, the steel along with it can also lead to seizures. It can lead to neurological deficits, as I said, because of steel phenomena. And of course, sometimes there is venous congestion due to venous hypertension. What happens? This vein is extremely high pressure. So the other brain parenchyma, the drainage that is happening slows down. So as we said in spinal malformations also, there is a venous congestion in the rest of the brain, because the rest of the brain's venous drainage is now at a slightly higher pressure. So gradient between artery and vein is less. As a result, there is congestion within the brain parenchyma. So this is the pathology. There is a high flow artery, and because of this high flow in this artery, there is medial degeneration and arterial wall thinning. So there is a bigger artery. Once you have an AVM, the feeding artery also shows wall changes. We would feel that the vein has to now deal with higher pressures. Only the vein will show arterialization. It's not that. The artery also now has higher flow because the AVM is a low resistance path. So the artery enlarges in size, there is thinning of the arterial wall and medial degeneration. Then you have the nidus part, which is the intermediate vessels between the artery and vein, and they have slightly hypertrophied media, but they do not have the usual capillary network, the parenchyma, and their flow is extremely high. Then there is the venous side now, which has to face the high flow, and it starts getting arterialized a little, but still there is no proper organized elastic lamina. As a result, it is bound to stretching and it can undergo rupture as well. In between brain tissue is very less. As I said, within the nidus of the AVM, there is less brain tissue. Of course, if it's a very diffuse, large AVM, there will be some brain tissue that may be seen in between. And of course, the other thing that you might find is the adjacent areas showing hypoxic changes due to the steel phenomena. That already we have discussed, and that can lead to neurological deficits and seizures. So the location could be left or right, and the thing has been found to be almost equal. There is no significant difference between the incidence of AVMs on left or right. And the deep structures or the posterior fossa, there is around 15% incidence, and they have slightly higher risk. We'll be discussing risk factors. Feeding vessels, again, whether it's from MCA, from ACA, what supply, how many branches, PCA, all that has to be studied. So feeding vessels are important. Multiplicity, sometimes you may have more than one AVM in one patient. And associated syndromes are there with multiple AVMs like Wyburn-Mason syndrome and hemorrhagic telangiectasia. So hereditary hemorrhagic telangiectasia, Wyburn-Mason, and there are many you don't have to remember, but two, three you should have in mind if somebody asks, and you should know that there are multiplicity is possible in AVMs. Now, the risk of rupture, as I said, without previous hemorrhage, it's around 1 to 2% per year. But if the patient has had one episode of hemorrhage and maybe survived that hemorrhage, then the risk is extremely high in the next year of a re-hemorrhage, because it is believed that there is a point which is weak and which can now again re-rupture. It is just like aneurysms. When you have an aneurysm, it ruptures, then the chance of re-rupture is extremely high. And but if it manages 3 to 5 years, and somebody tells I had this rupture 5 years back, then maybe it is as close to being an unruptured AVM. Spontaneous regressions are very rare, very few cases of documentation. It's mostly nothing that we believe or put it as an option for the patient that it may just go away on it.